Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and through this podcast, we hope to share good ideas, expose listeners to interesting minds and thought processes, and find African solutions for African problems. As always, views expressed are purely personal and do not represent any institutions that myself nor my guests represent. I'm very excited about this month's guest. He is our first international guest on the podcast, and his name precedes him as one of the world's oldest and smartest minds in global emergency medicine. Dr. Benjamin Wachira is an associate professor of emergency medicine. He is the past president of the African Federation of Emergency Medicine. He is the founder of the Emergency Medicine Kenya Foundation, and he is a past editor of the African Journal of Emergency Medicine. If anybody knows anything about emergency medicine in an African setting, it's him. And today on the show, we'll be discussing the state of emergency medicine in Kenya. We'll be discussing how to integrate new systems into old established healthcare systems, and we'll be discussing the immediate way forward in emergency care provision in low resource settings. I would also like to apologize for the slightly decreased sound quality in this episode. It was our first online recording. Welcome to the show, Ben.
You just call me old. I just say old mind. I'm not that old. And then you also call me clever. I'm not sure that also is accurate, but yes, here we go.
So would you mind just introducing yourself and giving us a brief rundown of your professional career so far?
All right. So my name is Dr. Benjamin Wachira, Assistant Professor of Emergency Medicine based in Nairobi, Kenya. My career so far, so I'm based at the Aga Khan University Hospital in Nairobi, but also founded the Emergency Medicine Kenya Foundation. Big chunk of my career has been focused on strengthening the emergency healthcare systems in Kenya and trying to get everything working. I think that's what's been part of my work.
Could you give our listeners a brief layout of the Kenyan healthcare system, from private versus public, and then the different levels of care that are available in Kenya?
All right. So in essence, they say 70% of, I think this was from the Ministry of Health, say 70% of Kenya's healthcare is provided by private healthcare entities, though that number keeps varying depending on who's talking about it. But healthcare in Kenya is a devolved function. Devolved meaning Kenya is divided into 47 independent counties, and each county is responsible for its own healthcare. So the Ministry of Health at the national level comes up with the policies and processes, but then the county governments within the 47 counties then are responsible for the delivery of healthcare. Healthcare is then delivered, there are 6 tiers. So there's level 1, 2, 3, 4, 5, and 6. So level 1, 2, and 3 are more primary healthcare level facilities. Level 4, 5, and 6 are more hospitals, with level 6 being tertiary hospitals, and a lot of the tertiary hospitals are under national government. In terms of distribution, so a lot of private facilities, and they also have the same hierarchy, but majority, I think, of the primary healthcare is majority of the private healthcare falls largely around primary healthcare, and the higher the level, then the less number of facilities. So, for example, from a private healthcare perspective, level 6 kind of hospitals are a handful. Level 5 a bit more, and then level 3. So it varies, but largely within the rural population, rural settings, the government is responsible for most of the healthcare. When we say private healthcare in Kenya, that also includes mission hospitals. So mission hospitals or faith-based organizations and NGOs are potentially not-for-profit organizations that have been set up by churches and other organizations that are pretty affordable and and provide good care. And so when we say 70% of healthcare in Kenya is private, it also includes this cohort of hospitals, which a lot of public do go to these hospitals because they're very affordable compared to the complete private hospitals. So large part of our public healthcare is provided by government, and there's faith-based and mission kind of hospitals. And then a small chunk is provided by private healthcare.
So faith-based organizations are accommodating for a population that cannot quite afford private care, or full private care, but can afford something to pay for their healthcare.
Yes, exactly. So the faith-based and the NGO hospitals serve a huge chunk of the public healthcare.
You introduced emergency medicine into a country where it never existed before. How did you go about bringing a completely new speciality into an established system, and how did you navigate the complexities of that?
So essentially, I came back, so I did my training at UCT and came back to Kenya in 2012. And since then, it's been a process of first understanding the existing healthcare system, understanding how it functions, and what are the current, what resources are readily available, and what are the gaps and why the gaps exist. So it's been initially a lot of learning and sitting with policymakers, both at national government and county government level, to really understand how things work and how the healthcare system is structured, but also then have discussions about, because emergency medicine and emergency care. So emergency medicine, I'd say, largely, or emergency care did not exist prior to this, largely because emergency medicine is not a specialty.
Prior to you going back to Kenya?
Yeah, well, there was a lot of discussions, but the biggest challenge has been emergency medicine was not a specialty in Kenya until 2017. And as I said, I came back in 2012, and following a lot of lobbying, we got it in 2017 to recognize our specialty. But a lot of also our advocacy and push to build the emergency care system spearheaded a lot of the discussions that have subsequently led to a lot of policies coming into place around emergency care, and some developments largely in the policy sector, where then now we have clear policies around emergency care and more being written and developed. But also then, because of the devolution of healthcare, then there's still the need to then develop similar at county government level. So, which is the work the foundation has been doing a lot of. So, while in certain aspects in your area saying emergency medicine, for us, we've been focusing more of it around emergency care and looking at how do we structure the existing resources to function systematically as prescribed, I guess, in the emergency care system framework by WHO. How do we connect these dots, make sure they have the right policies in place, and there's proper budgeting for this, both at national government and county government level. But then also make sure that there's training, because none of our undergraduate programs have emergency medicine as a specialty. And we only send a postgraduate diploma program. There's still not a robust emergency medicine master's program. So from a training perspective, there's still a huge gap in terms of developing the specialists and the speciality. But so we instead then started focusing on the healthcare workers working in ambulance services, the healthcare workers working in the emergency departments, and training them up and providing them with the necessary tools and resources to then be able to provide emergency care even without formal training. So a lot of the focus has been mainly first understand the healthcare system, understand its structuring, understand its budgeting and everything. And then now work hand in hand with the different governments to craft policies that are now aligning the healthcare system to address emergency care as a key component of the healthcare system. And we've done this so far in 21, almost 50% of the county governments. But they still, it's a journey for us to get to a robust system. And so there are very many components and we're trying to tackle each of them. But the end product ideally would be a functional emergency healthcare system in line with the emergency care system framework.
Okay, and since obviously that journey is a lot of fitting into what's already being done, as well as trying to advance a new system on an established system. From where you sit, you would probably be the most knowledgeable about an emergency care system, what it can look like, what it's supposed to look like. Have you had issues with implementing your ideas on on sort of politicians on the government side, as well as like other department heads and internal medicine and surgeons on what they have to think? Are they all sort of, are they easy to get on the same page and sort of think together and talk together about these things?
Let's start from the bigger picture. Currently in the country, if you're in an accident or you have an emergency, there's no number to call. There's no 911, 112, that number doesn't exist. So most of the time, you either try to figure out how you get yourself to hospital, or a neighbor will get you to hospital, or they'll bundle you up in a taxi or something and try and get you to hospital. And many people have died.
Are there any ambulance or pre-hospital systems?
Yes. So there are ambulances, but there are no systems. So essentially, most county governments would have 5 to 10 ambulances, but they don't do primary response, and most are used for interhospital transfers, and there's no central dispatching for these ambulances. There are some private healthcare private ambulances, but the only two that have widespread systems, but it's private and most people can't really afford to call them. So most people just stumble their way into the hospital. So a good number of people, and the same thing I normally say is, while I was training down in Cape Town, there are a lot of patients who we manage in the emergency department who in the Kenyan setting die because they just don't make it to hospital in time. From the acute illness to get into the hospital. I mean, there are patients who have 30 minutes max to an hour, and if nothing is done, they die. So in Kenya, 30 minutes is just when you're finally finding a taxi. So most people will die before they get to hospital. So that's the biggest challenge.
And then it's another long time before you arrive at the hospital. Yeah.
Exactly. So that's the first part of it. So when we start having these discussions, and sadly in a kind of good way, is when we have these discussions with everyone, and ask them, because everyone has been involved in an emergency, no matter who you are in this country, you either have been personally involved in an emergency or know a relative who's been involved in an emergency. So once we explain what we're trying to do and discuss with them, everyone can relate to a story where they were called, especially if you're a healthcare provider, and someone just didn't make it to hospital on time and they died. Yet if your ambulance, for example, was there, they would have been able to move forward. So across the system, there's been very little resistance to developing an emergency healthcare system. And COVID, for example, COVID was really a blessing in disguise, because during COVID time, politicians were operating as bed managers and ambulance dispatchers, because all their relatives and their friends were calling them to find an ambulance, to find a bed. So that really highlighted the gap that exists, that in emergencies, we should not be calling politicians.
It exposed...
Yes. Exposed the gaps in the system.
It exposed politicians to what actually is going on.
On the ground. So that was, and normally, and even on an everyday basis, especially with the devolution of healthcare, the politicians are always called for an emergency. And so in terms of identifying that, yes, we need to build the system, that was clear. So the other parts of it has been, so in terms of having policy around emergency care and a clear plan at county level around emergency care, that has been straightforward for everyone. In terms of having central dispatching for ambulances, so that has also been very clear, because again, it's been a resource that is ill managed. Half the time, maybe there's no fuel, there's no staffing. So they're just vehicles which are not really resourced. And again, the counties have identified this as a gap. We have a huge burden of road traffic crashes, and the ambulances never really make it to get people from the road. So the idea of having central dispatching and having an organized way of controlling the ambulances have been really well received. So the other part of it is the emergency departments. So again, because emergency care and emergency medicine has not really been developed in the system, most of the emergency, what we call emergency departments, are just outpatient clinics where patients just come in on a faster basis. And this, of course, everyone has known that a lot of patients have died waiting, or they have no resources within the emergency department. The staff have no training on that. So even the other specialities, again, in many of the public sector and the rest, they appreciate there's a gap in terms of there's a need for us to look at the emergency department and build the emergency department to be a department that is able to receive patients appropriately, triage patients, and provide that initial care. Largely also because the next level of care is not always readily available. The physician is not always, or the surgeon is not always readily available. So there's that need for the entry point of the hospital has to be able to stabilize these patients before they transition to the next level. So overall, there's been a lot of acceptance. I think the biggest challenge is how fast can we grow this and the resources needed to really solidify this on the ground, and the amount of training required, as I said, for the existing healthcare workers to be able to build robust emergency departments and robust ambulance services. I think that's the biggest rate limiting step in terms of, yes, we're doing some training, yes, we're trying to build the policies and the processes, but we still need a lot of, I mean, you could say this is an emergency department, but if the staff do not have the concepts around emergency care, then they may still not operate as a functional emergency department. So a lot of that still goes into the education pieces of it.
And since it's such a new speciality in Kenya, and as you said, a lot of the a lot of the hospitals' emergency units function as outpatient units and low acuity stuff already. You've almost got a bit more of a clean slate in terms of how you can define emergency medicine in Kenya going forward, and what skills you want to what skills you want to train your providers with, as opposed to somewhere like South Africa and other places in the world where it started out as an emergency unit where it was for emergencies, and the skill sets that we were being trained with were very emergency orientated. But because of the overburdening of numbers and failing of primary care and tertiary care and access to tertiary care not being high enough, they've sort of morphed back into outpatient departments because everyone just comes for unscheduled care at the emergency unit anyway. So we basically we are generalists and primary care physicians that can look after a sick person every now and then, type of thing. So is that similar to what you would see going forward in Kenya, or would you try and do something different from the start?
No, I think for here the biggest gap is where potentially you guys are headed, because if our emergency departments are not structured to be emergency departments, they are primary healthcare plus emergencies. So, and a lot of patients have died waiting in the emergency department, largely because there are no triage processes, no trained providers, no resources. So for us, what we're really focusing on, and that's why I'd say our focus is not to have specialists per se. I mean, down the line, it would be nice to have a specialist, but we really need to empower the people. First of all, we need to design these facilities, these emergency departments, so that there's a clear triage processes. And even now, there's a lot of drive by the government to build on the primary healthcare, so then people just go straight to the primary healthcare. and building triage within this emergency. So before there's been nothing. So it was all of you just show up and we will get to you at some point X. So our priority has been to build a triage process within this existing department. So then we're able to filter out the primary healthcare staff from the actual emergencies. And that has been going well. It still needs to be solidified across the entire system, that we have clear triage processes in every single facility. And then from that perspective then is then training the healthcare providers to, once you've triaged the priority patients, then being able to do something about the emergency and being able to provide that care for that emergency. And I think, the biggest gap is just it's not being able to, as I say, most of the healthcare providers don't have the actual training for this, and building this into the system. So I think one of the biggest, I'd say your biggest challenge, I'd say in South Africa, the problem is your emergencies do make it to hospital. I think that is one of the, and as you know clearly well,
it's the biggest problem.
Yes, that's your biggest problem, is all your emergencies actually do make it to hospital. And a big an emergency case is resource intensive when they show up. So it would be nice for us to get to that problem, because for us, anyone who has made it to hospital pretty much is not going to die immediately. It's a good number of them. Those who needed that acute care died before getting to hospital. So we're at a point where those dying in the emergency department surely actually should not be dying, because they have had a lot of lead time and someone should have done something with that to sort things out. But we need to build a system to get to a point where we don't have that problem. I can't say we have any emergency department or I've interacted with across the country where they've complained about them being overwhelmed with the emergencies and such. No, not really. And then largely, it's the same thing I'm saying, is they just don't make it on time. So we need to get to a point where as we build capacity for these emergency departments and hopefully get more patients coming in, then we will need to evolve with the changes. And hopefully in that space, then more primary healthcare will have been triaged out of the emergency departments into the outpatient clinics and outpatient hospitals, and then the emergency departments grow to just focus on emergency care.
I see. Yeah. So, and you have a sort of a nice head start on the rest of the world in a certain way, because you've seen where it's gone, the sort of directions that it's moving everywhere else. So you could predict this change and move with it and adapt towards it.
Yeah, I mean, if you ask me, the priority for any emergency department and emergency care physicians is to save lives. And being able to prioritize these patients, fine enough, we may have primary healthcare showing up, but we still need to be very robust with our triage processes to make sure that we are still focusing on the emergency cases, and the primary healthcare staff can potentially wait. But it's not nice to lose a patient in the ED because of a failed triage system.
No, and especially if they have, like you said, if they have had that sort of time period of they've made it to hospital now.
Exactly.
And now there's a period where you can actually do something about it. That should be the primary service we offer.
Yes, and that should be our priority. Is fine, there are a million patients in the department. Yes, you're all over. We'll get you eventually, but we should not be losing patients. And I think we need to double down on triaging, re-triaging, and always having that eye for the sick patients. The primary healthcare staff, they will get to them if we get to them. Yes.
So if you, just one of the other questions I'd written down, if you had we'd call it a magic wand or a genie in a bottle, and you could implement one thing with the unlimited budget, and that's not necessarily one thing like you could buy a new tertiary hospital or a burns unit or something. It's more like you could get more specialists to accommodate for like a tertiary system. You could get a functional pre-hospital EMS, like quick service. What would your limiting factor in Kenyan healthcare be at the moment?
I think what I'd prioritize, to be honest, is building the pre-hospital system to be very responsive.
Okay.
Because that's where most patients are dying from. And most patients, ideally, would be saved by getting them to a hospital. I think that would be priority number one. I think there's need for sure to do a lot of training. So that would be part one. That would be my magic one, would be fix the pre-hospital system so that we have more patients showing up in the emergency department. I always feel, in a crazy kind of way, that if an emergency department is constantly bombarded by emergencies, organically they will have to do better. They will, whether they have specialist training or not, they will have to do something about it. I think if you're running an emergency department anywhere and in a day you're losing 5 patients dying in your department, you make a plan. I think so, but we can only get there by making sure these patients get to the emergency department.
Yeah. So if you solve one problem, another problem will happen, but at least that problem will then generate a change in your policy or your training or something. But you'll cross that bridge when you get to a type of thing. Is that what you're saying?
Exactly. And people will make up. People will make a plan. So, but if we don't fix the pre-hospital system, then we really never understand the problem because people just die out in the community, and the normal response in our setting is, oh, they were too sick, so they died. So no one actually. And that's the problem we're having, the challenge we're having even right now, where we are giving people ambulance numbers. We're telling people to call ambulances, but because the system has never really existed and people have never really seen ambulance services work. So when someone is really sick or they're dying, then the normal response would be, well, they were too sick, that's why they died. So there's a huge mind shift that we need to really do in our system for people to understand, that we actually can save these people
and actually advertise to people.
Exactly.
Yeah.
That
I can tell people that if you get yourself to hospital, somebody might be able to help.
Exactly, but that won't happen if you're out in the community, and there are resources available, and that's what we're really building upon. So I think, for me, the magic one would be a functioning, I'd say 911 system, because that's what we all know, kind of. So a functioning 911 system. When they get to the emergency department, we will figure it out from there. But of course, then there's a need for us to develop and train the healthcare workers working within these emergency departments.
You said that in Kenya, a lot of people have a mindset that if somebody dies, they just died because they were too sick, and they didn't even try to come to hospital because of the lack of a perceived benefit of coming to hospital. Without knowing it, in some cases, not all cases, they might actually be practicing good principles of palliative care in that they're focusing on comfort and family support in times of terminal illness and non-reversible diseases, and they are actually benefiting the patient. In South Africa, a lot of terminally ill patients and patients with non-reversible disease processes come to emergency units mostly because of a lack of access to appropriate palliative care services that they need to access in a time of emergency for them. In Kenya, is there any palliative care service? And also, can you use your clean slate to your advantage to educate the public about when it would benefit them to rush somebody to hospital by accessing the ambulance service that you're setting up?
It's a good question. It's a problem that potentially lies a lot in the private healthcare space, but poverty is a good palliative care solution. Many people do not, because of poverty, do not get to the point where they need palliative care. They cannot afford that stabilizing care that palliative care patients need and potentially die. But the discussion is happening within private healthcare spaces, where then patients are being advised about palliative care, and it's slowly growing within there. But I can say this is largely a problem within the private versus public healthcare space. The public healthcare space, again, because most patients can't afford the expensive cancer treatments or that kind of chronic care, so their disease eventually does get just get to them, and way before they would need that discussion on palliative care.
Yeah, and you mentioned earlier that sort of faith-based organizations and donor organizations have a lot of input in Kenya and sort of provision for the public in Kenya. Um, how do they provide care and train their staff? Is it sort of interlinked with your emergency medicine foundation? Is it interlinked with the government? Are they all on the same page as you guys?
Well, they draw their staffing from the public training systems, so they don't have really any special staffings. They draw from the same pool that the government and everyone else is drawing from. But I think what some of them have done is they've invested in training their staff a bit more, and some actually have training schools within them that then train up their staff appropriately to meet the demands, even around emergency care. So it all boils. There's a lot of post training, post undergraduate training required for all cadres, doctors, nurses, clinical officers. So a lot of private and those faith-based and donor will invest in this. This is less and less in the government sector. Like I said, no one leaves the undergraduate program knowing how to handle emergencies. It's not really taught within the undergraduate programs, but a lot of them then will invest in basic courses and just CME training of their facilities. So what we are doing as a foundation for us is now focusing on the public side, because we know they are not getting the training. So a lot of our training programs are focused on building the capacity within the public government hospitals to make sure that they have the right training and processes within the emergency department.
All right. And is there, so I did a very brief stint in Malawi a few years ago, and you can even see it in South Africa, but there's a lot of things that are donated and a lot of aid that's given by sort of organizations, NGOs, NPOs, faith-based organizations, that is not always necessarily what the healthcare system needed in the first place. But it's given by like a donor, and it might not be very useful, like a ventilator to a primary care facility, and nobody knows how to use it or wants to use it, or it's a completely redundant thing. Is that a bit better in Kenya? Obviously these organizations have quite a well established founding in the system, and they probably know what is needed more so than most faith-based organizations.
I mean, we do come across the donated equipment from various donors and partners. I think one of the biggest gaps is not necessarily the donation, but the lack of capacity within the departments to use this donation. And like you said, I mean, I've been to facilities where they've been given ventilators, and well, they have everything. It's just the healthcare providers just don't know how to use these devices. So I think the biggest gap, I'd say, in that aspect is the donations do not come with training, which is one of the things we really avoided from our end. Is when we are giving out equipment, we have to train the staff on how to use the equipment. This is equipment. So that's where the gap is. So it's not that the equipment is not required. I mean, guys have been given point of care ultrasound machines, monitors, but they've not been trained on how to use any of these devices. But also, before there's lack of training and also lack of understanding, I guess, from even the healthcare providers of the utility of these devices and how these devices would be very useful for them. So it's two ways. And we've also experienced the same, where you donate equipment, but the facility is just not ready to use this equipment. Yes, they need one. They need a ventilator, for example. They are appropriate sized facilities, but they just don't have the capacity. I mean, and this again happened during COVID time, where ventilators showed up from everywhere and were put in facilities.
Everywhere. Donald Trump gave us some.
Yeah. And the equipment is fine. I mean, there's nothing wrong with equipment, but there is no staff who know how to use this equipment. You don't just put a ventilator next to a bed and connect a patient and voila. Like, there's a lot of resources that need to go around this. So the lack of planning around the donations and to see how they fit in and the additional resources required has been the biggest challenge. And this is what then happens, and the equipment then just gets dumped because there's just no capacity to operate the equipment.
Nobody to use it. And do you ever get asked about your opinion of what is needed and what can be given as a sort of figurehead of emergency medicine in Kenya? Do any of these NGOs come to you and say, Ben, what do we need? What do you guys need? Can we just give it to you, or can we give you money, or things like that?
So we do have the discussions. I've had discussions with a couple of organizations.
Yeah.
But I think one of the biggest challenges we've had with that also is, especially with some donors, is they come with preconceived ideas of what they want to do. So when you start telling them to scale down or do something different, they're not really willing to listen because they already planned to do this. So I guess most of the time, the consultations are happening at the end stage of the donation process versus at the big planning stage. So it's only when now they've implemented and they realize the problem, and that's when they come back and like, well, what do you think we should have done differently? But we told you this was not going to work. But yeah, so we do get asked whether that information is always used. Sometimes
but it's usually too late.
Yeah.
All right. And then, so I've read a few articles recently about there is a bit of a shift in a donor mentality towards a just, like they call it, the just giving phenomenon, where people are, instead of going through a whole like needs benefit and employing a lot of different people along that pathway of donating something and donating skills, it's more just giving money. So I think that could potentially help with the situation if you just provide financial backing to a system that can spend it in the way that they want. Would you agree with that?
I think it's more of a need for co-creation with local organizations. And also just sitting down. I mean, we go to facilities and sit with the facility heads and discuss, okay, what are the gaps in emergency care? What kind of help do you need? And this is how we do most of our programs. A lot of it is on consultation. So we as Emergency Medicine Kenya Foundation have an idea what the system should look like. But over the years, we've learned very well that there's what we have in our head, there's what has been prescribed by WHO, and we potentially can still get to where we need to go. But the path is not a straightforward path. And when you sit with the policymakers and the facility heads and start designing where we need to go, you realize that you need to solve problem A first, then go to problem B, then go to problem C, before you eventually end up where you actually want to go. So a lot of it, money, you need money for everything, that's for sure. But I think throwing money at the problem is not necessarily going to solve the problem. There's a need for co-creation and co-designing these solutions with the end users so that you're able to A, address their gaps, B, chart the way forward so everyone understands where you're going and what you really want to achieve, and then now implementing this. This needs to happen by just having everyone on the same table, discussing what they need to discuss, and then chatting the way forward. Yeah, so maybe I wouldn't say consultants and just go straight to the source, because every emergency department can tell you what their gaps are. and what the immediate challenges are
and what they need,
and what they need exactly. So with that, then
and how they can deliver a service.
exactly. So we understand the problems and potentially know the solutions. We just need the support to be able to implement the solutions.
And so, how do you see emergency medicine as a speciality in all its ways and forms? Being that pre-hospital systems, being that uh, emergency departments in your various counties, in your various bigger centers. How do you see it going forward in not only in Kenya but in the rest of Africa over the next, let's say, 10 years? Do you think it's mostly about establishing that training and getting people to hospital? Is that what you guys are going to focus on for now, or what are your immediate goals?
I think the first part of it again is there's a healthcare system that sees very many patients on a daily basis, wherever you are in the continent. There are resources in terms of emergency departments, even in the rudimentarist type. There are ambulances, even if it's just a vehicle with lights and sirens. So the first part of it would be to look at the existing resources and being able to connect them as defined by the WHO Emergency Care System Framework. Being able to have clear policies that define that framework within your locality and getting to a point where you can, when you have an emergency, you can call a number, a vehicle will show up that will then take you to an emergency department. I think if that would be the basics in terms of, and that doesn't need people to go back to school to do a master's in emergency medicine or go to EMS school to be pre-hospital providers. That just needs people to sit down and just connect the system. And that is doable.
Get a working telephone number.
Exactly. Yeah. And that is doable in any country or in many countries at this point. Once that is established, then now start looking at the individual components and what resources. I think the next part probably would be looking at the healthcare providers and starting to empower again the existing healthcare providers. Training takes some time, and yes, we should start training people, but before you can train enough people to cover an entire country's healthcare system, it will take years and not in our lifetime. But we can have these short course trainings to start empowering the existing healthcare providers in the pre-hospital space, in the emergency department space, and start building capacity. And the good thing these days with webinars and Zoom and short courses, you can pass on that knowledge and information quite quickly to as many of these emergency department and emergency and ambulance service healthcare workers, and start building that capacity from a knowledge and skills perspective. And in the same line, of course, they're now focusing on the postgraduate training, whether it's a diploma level, which is our certificate level, some form of institutional training, diploma, certificate. Have all of them: certificate, diploma, higher diploma, degree. Just get more people trained and have them then come back and work on the system. But as I said, it's if you're saying we can't say we're going to wait for faculty level masters of emergency medicine people to be trained before you have an emergency care system, or we're going to train our paramedics before you have an emergency care system. I think starting with what exists at the moment, starting with the resources that are currently on the ground, the people on the ground, then building this up into then the higher levels training is how we're going to solve the problem. I think a lot of people are very ambitious and want to start at the end and not really realizing that a good chunk of the resources already exist. We just need to connect the dots and upskill the existing people.
In terms of connecting the dots that already exist, has anyone in Kenya done any work into telehealth and tapping into sort of consultants and sort of advice providers in any form via remote medicine and sort of WhatsApp video calls, things like that? Is there like an app that people can use?
So there are multiple apps that have been developed. How many of them are robustly functioning? Not that many. The thoughts have been there, but the culture and the system has not. Again, it's a situation. It's a case of everything is ready. It's just the system is not ready for this. And everyone keeps talking telehealth. The government is on about telehealth. But the problems that, the challenges and problems that our patients face and our healthcare providers face is not necessarily a knowledge or a telehealth problem. It's there are no drugs in the facility. I can't get this patient to the right surgeon, or there's no. So it's not a knowledge thing. I feel like telehealth solves a knowledge gap. Our current problems are service gaps, not knowledge gaps. And with Google, we can all Google some answer or something. So that's the biggest challenge. So
you can figure out the patient needs.
Yeah. So
you can figure out the patient needs surgery, but if there's no surgeon, you can't do anything.
Exactly, and that's a challenge right there. So there's a lot of discussions around telehealth, how we need to go telehealth. I mean, government is pushing for telehealth, but the reality is it's not. I feel telehealth is a knowledge gap issue that would be bad. That's not the problem. The problem is we can't get patients to the right place at the right time, and sometimes do not have the resources to provide the care that the patient needs.
In terms of the provision of emergency care and resources and actually getting service on the ground, you have obviously undertaken a huge task in developing systems in Kenya and around Africa, which we commend you for. And we obviously need to find ways to continue the momentum, continue the pressure on the politicians and the budgets in what seem like economically austere times.
I think it's a good discussion, and I think it's a discussion that many countries need to have, because the more we do not start developing our systems, the more patients we end up losing. And as I always say, if I've been in an accident, as much as an emergency physician and I know how to take care of trauma, I can't treat myself. And there's a need for us to focus really on building the system that will take care of you, yourselves, and your loved ones, because at the end of the day, they are the ones who will be needing that emergency care. You may find yourself needing emergency care. I have been in a situation where I've needed emergency care, and I was taken to where I work at the hospital, and they have a system there, so that worked. But I was thinking, had I been taken to any other facility, I potentially would not have been made it. So for me, the drive to build our systems largely is from a selfish perspective, because I may require the resources at one point, or the services at one point, and that extends to my family and friends. So it's good to be trained in emergency care. It's good to have the knowledge and skills, but if the entire system doesn't work, then sadly, you may find yourself a victim of the system that you should have helped to build.
And also, just from a professional point of view, what you obviously trained as an emergency physician, you know a lot about clinical medicine, but from the way you've been talking, you seem to be very involved in public policy, system planning, and things like that. What are you doing on a daily basis? Like, how much clinical medicine do you do? And have you found that which side of the land do you enjoy more? You've got a very big sphere of influence now, but
so I teach a postgraduate diploma in emergency medicine at the university. So that gives me the academic, I keep up with the academics because of that. But in terms of clinical time, it's very minimal to almost none. I mean, I'll do ward rounds in the department and just oversee the clinical care patients are getting, but direct care is very minimal. But I always, and I've had these discussions again with my bosses, hopefully they won't be listening to this podcast, but I could sit and see patients and influence the one patient that I will see, and the two patients and the three patients, or I could build a system and everyone benefits from the system. So as much as, yes, clinical care is the easiest care you can give. You see your patient, you're done, they go away to the next person. Building systems is what keeps me up at night. And for me, the benefit I see is if we build the system, then many more patients will benefit from my knowledge and expertise than if I sat in a cubicle seeing one patient at a time.
Thank you so much for joining us on the podcast, Dr. Wachira. You've offered many insights into emergency medicine systems in Kenya and in a low resource setting. And we look forward to chatting to you next time. And good luck with all of your endeavors.
No, I'm glad, and this has been an exciting discussion and happy to do more.
That's all for this month's episode. Thank you so much for joining, and I really hope you found that discussion interesting. As always, please like and subscribe on all of your main platforms and share episodes amongst your colleagues and friends. Also, if you want to get in touch, please do so at dan@badem.co.za, and please visit our website www.badem.co.za for lots of old content. We will see you next time.